thank you again for giving up your time. It is you, the people in the system, who really have an important part to actually make this happen. I'm going to, just for those of you who don't know, the Bevan Commission is the independent think tank for health and care in Wales. I'm sure you're all aware of that by now. But basically, we are supported by 24 international renowned commissioners who give their time and expertise to us for free. And there are three components of work that we broadly address. The first one is challenging. We shine a light on big challenges and ask questions that matter. And of course, this is one of those things that really matters. In other words, you know, what are we doing that we shouldn't be doing, and where are the silly rules that get in the way? We ensure that we change, so we don't just say, well, there we are then, and walk away. We try to use whatever we can, whether it's evidence or ideas or insights from people such as yourselves, to find some of those practical solutions to make that difference in practice. We can print all we want on paper, but actually it's people like you that will make that difference. And thirdly, championing. It is people in the system who will help us change the system. We recognise that for some time. So that's enough from me. This is just a short session. So I'm going to hand you over to Tom, who is going to bring you up to speed with where we're at. Thanks, Tom. Tom, you're on mute.
Sorry, let's start again. Can everyone hear me now? Yes?
Yes.
Okay, fantastic, thank you. So good afternoon, everyone. My name is Tom House and I'm Head of Transformation and Innovation at the Bevan Commission. So it'd be good if we could just start with a quick show of hands. So if you've put your virtual hands up, if you've experienced any of these or know someone who has. So it's definitely not a test. It's about seeing how common these experiences really are. So what struck us before the work and what strikes us now is that these aren't rare events. Repeating your story, receiving letters after appointments, carrying paperwork between services, or following rules that nobody can explain are everyday experiences across health and care. That's exactly why we launched Silly Rules campaign. So rather than accepting these as just the way things are, we ask people to identify them, challenge them, and help us remove them. Because improving healthcare often starts with removing things that just don't add value. Each one of these might seem like small frustrations, but together they represent waste, wasted time, wasted effort, unnecessary cost to the system, and avoidable frustration for patients, staff, and the wider system alike. So micro changes at scale we know create macro value, and that's exactly what this work's about. No single silly rule will solve the NHS challenges, but removing thousands of unnecessary steps and complications will only add value to what we do. Fundamentally, silly rules is about waste. Every unnecessary step, duplicated process, and arbitrary rule consumes time, effort, and resources without adding value. So the evidence suggests this isn't a marginal issue. So international suggests that 20 to 30% of health and care resources are wasted through activities that don't improve outcomes. In Wales, that's obviously a significant opportunity. We spend around £8.7 billion on health and care each year. And removing potential unnecessary waste modelled could release around £2.6 billion. Obviously, that's not all in monetary terms, but this is just a high-level assessment of that 30% if we were to reduce that waste. So just to be clear, this isn't £2.6 billion sitting in a pot waiting to be spent. It's an illustration of the value that could be released by systemically and systematically removing waste from the system. So that value is realised as time, capacity, productivity, better use of resources, less frustration, probably better staff and patient well-being, not simply just cash, although cash is a part of it. The prize isn't just saving money, it's creating capacity to deliver more. and better high quality care. So waste being removed is capacity created. And these are just some high level, very much examples of what that could relate directly to. Again, not cash, but just examples. So our Let's Not Waste campaign showed us that the waste isn't just about money. It exists in many forms across health and care. It spans workforce, services of energy, treatment, systems, and admin. One theme came through time and time again. So admin and bureaucratic waste was one of the biggest sources of frustration for both staffs and patients in the system. So it's often hidden in plain sight. So duplicated processes, unnecessary paperwork, repeated information, and rules that add effort but not necessarily value. So if we're serious about improving productivity and releasing capacity, tackling administrative and bureaucratic waste is key. So where did the Silly Rules campaign begin? So it was inspired by the work of Professor Don Berwick, one of our commissioners and the former president and chief exec of the Institute for Healthcare Improvement in the USA. He describes what became known as the bicycle book rule. During the Second World War, staff who cycled to work had to sign a book so they could receive extra food rations. The remarkable thing about this wasn't the rule itself, it was that it stayed for around 75 more years. People were still signing the book, despite the war ending many years earlier. No one questioned, but the practice still happened and wasted value. So the simple story captures the essence of silly rules today. So how many silly rules persist, never get questioned, but continue to waste value? Silly rules isn't about blaming people, it's about challenging the processes that no longer make sense within our system. So in essence, what Silly Rules tried to achieve was to capture the countless small rules, processes, and administrative barriers that no longer added value to our system. Not because they were malicious or intentional, but because they've accumulated over time and simply become the way we do things around here. These unhelpful rules waste time, consume resources, and frustrate patients and clinicians. By identifying and removing them, we can release capacity, reduce bureaucracy, and allow people to spend more time delivering care rather than navigating an overly complex system. So what we did, we took this idea and tested it here in Wales in partnership with Llais. Rather than telling people what to do with what we thought the problems were, we asked them one simple question. So if you could break or change any rule to provide a better care experience for patients, families, or staff in Wales, what would it be? Importantly, we asked both health and social care professionals and the public, because bureaucracy and unnecessary rules affects everyone that interacts with our system. And the response was overwhelming. And what people told us revealed just how much hidden waste and silly rules existed in our health and care system. So on to what we found. So the responses exceeded our expectations. We received over 780 responses from more than 110 different organisations, identifying over 800 silly rules, which we then themed into 10 common themes. What was particularly interesting was that these fell into 3 distinct categories. These were national or policy rules, local or organisational rules, or simply not rules, but just myths and cultural beliefs. And this tells us that tackling waste isn't just about changing policy, it's about changing culture, challenging assumptions, and giving the people permission to ask, why are these rules here in the first place? So in terms of who responded, the profile closely reflected the makeup of the NHS Wales workforce, with 72% female respondents and 25% male respondents. And this is very similar to the gender distribution across our system. This gave us confidence that these findings reflected real system-wide experiences rather than isolated opinions. And this slide provides a bit more context about the responses we received. So on the left-hand side is who responded. So were they healthcare staff, social care staff, member of the public, or didn't specify? And on the right-hand side, this relates to what area the rule applies to. So whether this is healthcare services, whether it's social care services, whether this was both, and whether they didn't specify. So together, this gave us a rich picture of where unnecessary bureaucracy and waste are being experienced across the system. Geographically, we also looked at where the responses came from across Wales. This map shows the geographical spread of responses from professionals across each of the health boards in this instance. We generally got much less response from social care, so we've just here modelled it on healthcare services. And as you can see, the responses were fairly evenly distributed across Wales. We had challenges communicating in some areas and struggled with buy-in in other areas. But hopefully you can see that the responses reflect, hopefully, the footprint of most organisations in Wales across NHS health boards. So how did we then analyse them? So looking at the themes and using coding methods, we looked at the raw data, and what we did was identify 10 core themes that fell out of the data, really. These are clinical services, operations and service delivery, workforce and HR, finance and procurement, digital and information, quality and patient safety, strategic plan and transformation, public health, comms, and research and innovation. As you can see on the right-hand side, we then could weight them by frequency. So whilst issues were identified across every part of the health and care system in terms of these themes, one group particularly stood out, and that was operations and service delivery, which accounted for by far the largest proportion of submissions from responses. So what did this tell us? So this almost reinforces what we already discussed. Much of the waste people experience isn't in clinical care itself, it's often hidden, but in the processes, administration, and the bureaucracy that sits behind it. However, the remaining themes, such as quality and safety, planning and transformation, clinical services, these all highlight different opportunities to remove waste and improve value in different forms. So just delving a bit more deep into the operations and service delivery element. So what did people actually say around this? And these are just some of the real examples submitted from respondents across Wales. These include an administrative burden and contact barriers, as I'm sure you've all experienced. So having permission to try new ideas without needing to write multiple SBARs and seeking permission from multiple people and boards. The second I found quite interesting, and this is hospital-based team coordination. So enabling all, considering the capacity demands we have across Wales at the moment, enabling all consultants employed by NHS Wales to work in any health board across Wales without bureaucratic checks. They've all been through the same process, same HR processes, and have the same standards and checks. So why aren't we allowing them to do so anyway? Others included challenges around the waiting lists and clinical triage. So the unwritten rule and practice of sending ambulances to all chest pain from NHS 111 originating calls, and we'll come on to this as a more in-depth case study as we move through. But there are also obviously other barriers around time and resource pressures, so funding service and equipment without going through lengthy procurement processes. I think this is the sort of one we saw quite often. We saw examples of procurement processes having to be done for boxes of tissues and huge sort of trails for small items, and repeated processes, so requiring GPs to write up and sign Mars charts for district nurses who have done them before to administer medication. Just a few examples from digital as well. So I think we all can relate to many of these, I'm sure. But digital was another source of frustration. But interestingly, the challenge wasn't simply a lack of technology. People consistently describe digital systems that don't talk to one another, that duplicated data entry, that they had to use paper-based workarounds, had to tackle complex information governance, and multiple systems doing the same thing. In many cases, digital was actually creating work for the system rather than removing it, adding clicks, duplication, and delays, instead of simplifying the process, which is already complex enough. The results familiar. As we see from all of these, we can see wasted time, we can see frustrated staff, we can see poorer patient experience, and resources diverted away from frontline care, which is the ultimate responsibility of healthcare, is to provide the best health and care services that we can. So interesting for me, this shows us that digital transformation isn't all about introducing more technology. And it can be seen as removing unnecessary digital friction, and think how much that would transform day-to-day lives and the digital infrastructure in which we focus on and work by every day. So just examples from the screen. So data sharing was a really big one, especially when we looked at the integrated care domain. Manual processes and paperwork, which I'm sure you all experience on a day-to-day basis, as well as just too many multiple systems that don't talk to each other and don't reach out. So efficiently navigating and supporting patient care where systems don't talk to each other is inevitably significantly challenging. So let's now dive into a bit more depth. So these are just some modelled case studies. So we really wanted to be able to show you what does this actually mean to the system? Considering we had taken into account and think we had over 800 individual rules, and this is just one example of some high level, and I suggest high level, because this very much is, we can't say this is, we fall on our spike for the rigor of this, but this is just illustrative to give us an example. So understanding and identifying silly rules was only one half of our story for the report. We also wanted to understand the value of fixing them, removing them, or overcoming them. So what we did, we selected a number of real examples submitted through the campaign and applied a high-level modelling process using operational assumptions and published costs to estimate their potential impact. This example is one that many staff will recognise, I'm sure, and probably most people on the call today. 5 systems, 5 passwords, 1 patient. Clinicians repeatedly logging into disconnected systems and re-entering information. When you start to map that journey, potentially between 20 and 60 minutes can be lost for a single patient interaction scaled across. When we scale that across 10,000 frontline staff, that equates to around 3,300 hours every day across Wales. And that's the equivalent of around 416 clinical shifts. Or if we were to put a financial value on this, that's about £42.5 million a year lost in workforce time. Again, not money that you can be able to spend, but if we account for the cost of capacity, this suggests we might be looking at a £42.5 million saving. What we can see here is that small digital inefficiencies repeated thousands of times become major points of system waste. And this is something we really need to consider as we start to transform and move forward. The second example came directly from frontline staff and relates to an unwritten operational rule within NHS 111 call handling. In practice, many chest pain calls are automatically escalated to a 999 response. And in many cases, it's obviously the right thing to do. But these are escalated even when there are no obvious red flags because of different algorithmic pathways, risk aversion, and limited opportunity for clinical discretion in instances. Again, when we start to map that journey, you begin to see how one operational rule creates consequences throughout the system. So ambulance crews become tied up in attending low acuity cases. Emergency departments receive additional attendances that shouldn't necessarily be there. Clinicians then face pressure to admit or investigate because the person has been relayed to hospital. And these patients then experience longer waits. So you can start to see how it's not just a single point of inflection. There's multiple ripples throughout the system of any one silly or unwritten rule. So using a conservative assumption of just 10 avoidable non-urgent chest pain dispatches per day by the ambulance service per health board, the modelling suggests around 25 hours of ambulance crew time could be released every day if we were to overcome this somehow. And that's equivalent to more than 3 full-time ambulance shifts. If we were to look at this through the financial lens, which is important, but again, this is modelled and it doesn't release cash directly, we could be looking at potentially or approximately around £1 million of avoidant ambulance activity per health board each year. Or when we look at the whole system across Wales, around £5 to £8 million. And that's before considering the downstream impact on emergency departments and wider hospital flow.